Paviaplay.it. Accende il tuo territorio.
Important seminars for doctors and pharmacists and students who want to look the future of clinical pharmacy. Anchoring the past makes no sense if the future makes work easier and cheaper, more effective and more efficient. It's very important to learn to work in an efficient team, particularly in specialistic wards such as internal medicine and geriatrics wards and emergency departments. Organized by Prof. Simona Collina, Dean of Pharmacy and CTF Courses, Prof. Giovanni Ricevuti, Teacher of Clinical Pharmacy at University of Pavia, with the collaboration of Department of Drug Science, School of Pharmacy, University of Pavia, Erasmus Office of School of Pharmacy, conferenza permanente dai direttori delle scuole di medicina di emergenza ed urgenza, conferenza permanente dai direttori delle scuole di specialità in farmacia ospedaliera, PhD in Biomedical Sciences, Harvey School of Medicine, University of Pavia, Master in Crisis Management in Healthcare, Emergency Medicine, Italian Society of Clinical Pharmacy. We will discuss the nuances of the modified approach to take with seniors and lead into the discussion of polypharmacy, geriatric syndromes and problems among geriatric patients in the ED.
Okay. Thank you very much for your presence at this final seminar of Professor Cole. Now we are starting our lecture. We are starting our lecture. This is the last lecture of Professor Cole, and we will discuss many topics related to clinical pharmacy. Please, thank you very much.
All right, thank you everyone for tuning into this lecture and those of you that are here in the classroom. So yesterday we talked about clinical pharmacy practice in the inpatient setting or in the hospital. So today we'll talk about clinical pharmacy practice in the community and what clinical pharmacists do outside of the hospital. But before I do that, I got a lot of great questions both during the lecture yesterday and while we were at dinner about what the pharmacy school looks like in the United States, and potentially if pharmacy students from Italy could transfer into our pharmacy school and if any of the classes would transfer over. So I just kind of wanted to give you guys an idea of what our pharmacy school looks like so that you could kind of determine if you feel like your classes are similar and if the teaching style is similar to what we do in the United States. So I'm going to use the pharmacy school that I went to, which is the University of California, San Francisco, as the example of what a pharmacy school curriculum looks like. So I think one of the biggest differences and what the curriculum has changed over the last, I think, 3 to 4 years is that we have what's called a flipped classroom model. And so in this model, instead of you going to the classroom and learning about all of the medications, how they work, and really just that didactic knowledge, you do that at home. And so you read all of the textbooks, you watch the lectures, it's a lot of YouTube videos, and so you learn all of kind of that baseline knowledge when you're at home, so that you have that information when you come to the classroom, so that when you're in the classroom, you can apply that knowledge. So what you do in the classroom is you work in small groups on patient cases, working through different clinical scenarios. And so you work within a team. And so you start building that teamwork environment and skills that you do in the real world. And your teacher is then there to provide you feedback. And then after class, you then continue to expand the knowledge and look into any of the information that you didn't know while you were doing your small group activities. And I'll have a video on more of this in a few slides that I hope will help you continue to understand what this flipped classroom model is. And so why do we do the flipped classroom model? So it's been decided that kind of the traditional transfer of just simple information from your teacher to the student doesn't prepare students for the workforce. It really doesn't prepare the students to get out into the real world and sufficiently take care of their patients in this incredibly ever-changing healthcare environment. And the accrediting bodies for the pharmacy schools in the United States now require that students can recognize social determinants of health and diminish disparities and inequities across quality care. So pharmacists don't just need to know about medications anymore. That's really kind of just the start of what pharmacists need to know. They need to know how to use medications across different patient populations, across different health literacies, and really just across the world. And so now teachers focus on helping students develop their critical thinking skills, their cultural understanding, how they have empathy with their patients, so how they communicate with their patients, and how to work within a team. So it's a much different focus on what the teachers provide their students than it used to be. And so what are the benefits of a flipped classroom model? So students really take ownership of their learning. They do all of their didactic learning at home. That really helps promote self-centered learning and then collaboration with other students once they get into the actual classroom. And the lessons and content is more accessible because they have it all at home. And this really facilitates cooperative learning. So learning with others, so that, because you know when you get out in the workforce, you're not by yourself. You're able to ask your colleagues questions. You're able to lean on what the strengths of your colleagues are. And so this really starts in the classroom right when you start pharmacy school. So I want to exit out of my presentation and show you a short video that further describes this. All right, can you guys at home all see the video? Yeah?
Yes.
Okay, perfect.
Is a new method of teaching that is turning the traditional classroom on its head. Every day, thousands of teachers deliver the exact same lesson in class to millions of students. Every night, millions of students sit over the exact same homework, trying to figure out how to solve it. The flipped classroom is turning this upside down. Traditionally, students listen to lectures and take tests in class, and read textbooks and work on problem sets at home. In flipped teaching, students first study the topic by themselves, typically using video lessons on YouTube, and then apply the knowledge by solving problems and doing practical work in class. Modern schools who flipped their classroom report many benefits. 1. It allows all students to learn at their own pace, as videos can be watched again. 2. It's more efficient, as students enter the classroom prepared to contribute. 3. It enriches the classroom, as more time can be spent on group work and projects. 4. Doing homework in class allows students to help each other, which benefits both the advanced and less advanced learners. Flipping also brings changes for teachers. Traditionally, teachers engage most with the confident students who ask questions. Flipping allows teachers to target the students who really need help, instead of just those who are confident. Also, instead of instructing from the front, teachers guide on the side. This allows them to work more closely with individuals or small groups. Teachers that are not great presenters can use third-party videos to explain the concept and focus on methods of teaching that suit their style, such as project work or experiments. Once video lectures are made available online, teachers don't need to give the same lecture over and over again. Again, they gain more time to focus on the needs of their class. Many scholars also argue that the flipped classroom model promotes equal learning opportunities, as all kids get the same attention when doing their homework. Currently, kids with caring parents, older siblings at home, or expensive private tutors have a clear advantage over those who don't. Let us know what you think. If you were a teacher,
Okay, let me go back to my presentation. All right, can you all see the presentation again?
No, not yet.
Oh, is it this one? Can you see it now? Yes. That's it. Okay, perfect. So that is the flipped classroom model. Does that look like how you teach here in Italy? Are students expected to kind of learn the didactic information at home, and then when they're in class, you work on the homework and you work on patient cases and really work as a team in the classroom? Or do you guys still do more of the didactic kind of teacher to student education in the classrooms? Mm-hmm.
Well, it depends. In which way? Of course, in the degree.
Mm-hmm.
For example, in pharmacy here in Italia, you have to go to the professor, go to the lecture,
Mm-hmm.
hear the professor. Sometimes professor asks to do an essay, maybe sometimes. And of course, there are lots of
Mm-hmm.
students. But in my experience, not groups, two groups, not more.
Mm-hmm.
But you have to do works in the lectures.
Mm-hmm.
On the other hand, you can do a team group
Mm-hmm.
if you go to the labs, which is quite a lot. But basically, if you go to the lecture in the university, it's just to hear the professor,
Mm-hmm.
and then you go home and study, and that's it.
Mm-hmm.
But it depends again.
Right.
In which degree.
Yep. So it sounds like in Italy, it's still more of the traditional teaching style where you go to lecture, you listen to the professor lecture for however amount of time the class length is, you go home and study. You do have laboratories where you work in small groups, but primarily the teaching is still that traditional lecture format. So this must be pretty new concept for many of you. Are there any questions that you have about the flipped model before I go into how it looks in a pharmacy curriculum? Okay, maybe you'll have some questions at the end, but essentially the flipped model of teaching is founded on this constructivism theory, in that learning is really constructed and information remains with you when it is based on real world experiences. And so we'll talk more about that. And so at UCSF, the motto for the pharmacy school is for pharmacists and pharmacy students to be inquisitive, not to just know the information, but to continuously ask why. So their motto is ask how, ask why not, and ask what if. So they really want their students to be forward thinkers and innovators rather than just knowing medication information. So they really want their students to question the status quo and to continue moving the field of pharmacy forward. And so their three main focuses are building the core knowledge, which obviously you have to do to become a pharmacist, to experience pharmacy practice. So you'll see throughout what I described with the curriculum, there's a lot of hands-on experience, both with actors that are pretending to be patients, going out into the community, and then having the rotational experiences. And then the last focus is to explore new ideas, innovations in science, and practice while you're developing your inquiry skills. And this is kind of a new thought process for pharmacy schools, to really be these inquisitive thinkers out in the medical field. And so this is what the first year of pharmacy school looks like at UCSF. So you'll see you have orientation beginning in August, and then you focus on foundations, APCS, which is your applied clinical skills, and then your IPPEs, which I spoke about the IPPEs a bit yesterday, and those are your introductory pharmacy practice experience, and that's when you actually work in the pharmacy field, whether that be in a retail pharmacy or in the hospital. And so you'll see that this is kind of a progressive layer of learning with each block, because the foundations is when you're in the classroom. The APCS is when you're trying out your skills on paid actors or patients, so that you start to build your communication skills, you start to build your confidence in practicing this, and then you go on to your IPPEs out into the real world and do it for real. So this is kind of how they layer progression in each block of schoolwork throughout the year. And then you'll see that when they actually start talking about different disease states and medications, they do it in organ systems. So you'll see the first one in the fall is the cardiovascular system. And they do it this way so that students really build knowledge from the ground up. So they start with the physiology of the cardiovascular system, so they understand how the heart works, how blood flows throughout the body, so that when they start talking about disease states and medications, they understand more about how that works. And so that's why it's broken up into different disease states rather than simply just learning about different medications at different times. So we'll start off by focusing on the foundations. So when pharmacy students first enter the pharmacy school, what are they learning about? So they first learn about the therapeutic sciences, which is kind of expected. So they learn about how the drugs work in the body, how any drugs work in the body. How do drugs bind to different receptors? How are drugs metabolized? How do they distribute throughout the body? And so this is really just basic information about when you take a medication, what happens to it. They're not focusing on any disease state, they're not focusing on any certain medication, just what do they do in the body. And then the second area in the foundations is the inquiry. So this is really, how do you analyze drug information, and how do you analyze drug trials and determine if the conclusions from the drug trials match your population. So you learn about epidemiology, public health, you learn about how studies are designed, and you learn about different health equity and health disparities. So when you think about treating different patient populations, what does that mean? What does medication access mean? And so you can see that early on in the first semester of the first year, they're already teaching pharmacy students about different aspects of the world and treating different patient populations. So it's a much different focus than simply teaching about medications, because that's what the students are doing at home on their own time. And then the last phase of the foundations is learning about social and administrative sciences. So this is really teaching pharmacy students how to navigate the changing healthcare environment. And really, again, they use that innovator and how to be a pharmacy leader. So how do you create different healthcare policies? How is leadership developed within a health system? How is medication safety and quality ensured? So this is teaching more about the administration side of medications and teaching about pharmacy law. So again, these are very kind of unique topics to learn so early on in a pharmacy career, but it helps pharmacy students start developing their thoughts about the field of pharmacy overall.
Only theory or practice?
So this is just theory. And then, so you learn about it, and then we move on to our APCS, which I'll talk about next, and that's when you start being more hands-on. And that's how they layer their teaching. They teach about it, and then you move to the hands-on training so that you solidify your confidence before moving on to the next topic, where I think most of our pharmacy schools in the United States teach all of the topics before moving on, and that's just a lot of information to become confident in the end. And so they do it kind of piece by piece. And so this is the applied patient care skills. So this happens in each semester, and typically at UCSF, they hire actors to act as patients. And so they sit in exam rooms, and you go in the exam room and you talk to the patient about whatever condition they might have. You talk to them about what laboratories you might order based on the condition. You interpret the laboratory results. You might take their vital signs. You might take a medication history. And so again, this patient interaction happens very early on in the pharmacy school. So you start building your communication with patients. You start understanding what sort of questions you would ask out in the real world. And so this is when you start getting those hands-on skills. And then after each block, you have what's called a synthesis week and inquiry immersion. And during this week, you actually go into small groups with medical students. And you discuss different patient cases that involve gender identities, health inequalities, medical illiteracy. So you talk with physician students that you would interact with out in the real world about barriers to healthcare, about how you would treat different patients differently. And so this really does model what you would do out in the real world. And so that's, I probably have said that 10 times now, but they really want to help the students grow their knowledge of their practice early on. And so year 2 is very similar to year 1 in that you have a much shorter foundations block, and I'll show you what happens in this foundations block. But then you essentially continue on and just doing different disease, different organ systems throughout the second year. And again, they do that layered learning. So you learn about the organ system, and then you go and talk to fake patients essentially about it, build your confidence, and then you go out into the real world, into the actual pharmacy, and further build that confidence. And so the Foundations 2 that happens in the second year is teaching the pharmacy students how they would prescribe medications or use medications differently in different patient populations. So we talked about geriatric patients on Monday. They start learning about the differences in geriatric patients. The LGBTQIA population, how would you talk to these patients differently about their medications, about the goals of their medications? You learn about health disparities. So again, just teaching about the patients in the world that you will be interacting with after pharmacy school and how you need to change the way you think about medications. And so that's your first and your second year. The third year is spent doing your advanced practice pharmacy experiences. And so there's no didactic training at all in your third year. Each block is a different experience within a different pharmacy, whether that be different pharmacies in the community setting, whether that be different experiences in the hospital. And this is where students get to start picking where they think their future career will be. So if students are interested in the community setting, they can select more experiences that are like that. I was more interested in the hospital setting, and so I chose different rotations throughout the hospital. And so you can really customize your third year to gain more experience that can then help you apply to residency after pharmacy school if that's what you're interested in. The Discovery Project is kind of an interesting concept. You get to pick a clinical question that you find interesting and then work within a team to answer that question, and essentially it just lasts all year. And that really just helps you solidify your ability to gather information online. So you learn about all the different resources. You have to write a manuscript. So you get sort of research experience in writing a manuscript. And again, doing all of this within a team. So again, continuing to build your teamwork skills. So I have kind of an example of how that would look based on a disease state, but I want to pause and just ask if anyone has any questions about the structure of the 3 years of pharmacy curriculum.
It's totally different we do it in
Mm-hmm.
Because at the third year, we are keeping studying, we are keeping going to the lecture, and actually we can just go to the pharmacy only just moving.
Mm-hmm.
So, and just for, I think, 1 semester,
Mm-hmm.
if you're lucky.
Right.
And it's really totally good. So, it's really good.
Mm-hmm.
Great. And another question is, so you choose in your experience, you choose which words you are going.
Mm-hmm. Yes, so the comment for those online is that the curriculum is just so different because the pharmacy students here don't have that experience in a pharmacy until the 5th year. And then when you do have that experience, it's much shorter. And so this definitely goes back to the focus of our school in getting that hands-on training. The thought is that pharmacy students can learn the medication about information on their own time. They're smart enough to read a book and listen to lectures, but what they cannot do is get the experience, the real world experience, and build those real world skills before going out into the profession. So that's the focus of the school. And then the other question was, for this 3rd year of pharmacy school, do we actually get to pick what wards we go to? The answer is yes, kind of. So you get to rank what wards you want to go to, 1 out of 10. And it is a lottery, so you don't always get all of them that you want to. I would say you get the majority of the ones you want, but for example, emergency medicine is very popular these days, and so a lot of students pick emergency medicine, and we can't post all of the students, and so probably 80% of the students who rank it in their top 3 get it. So you might get ones you don't want, but you get the majority of the ones you do want. Any questions from home? The people at home, does it make sense what I said?
So probably your course is more oriented to clinical aspects than theoretical information.
Yes.
Yes.
Yep.
But about the people that would like to do research or to be employed in a pharmaceutical company, how can you prepare these students?
Giovanni had a good question. So the school that I went to was very much focused on training clinical pharmacists. However, we do have students who are interested in, say, working for industry at a pharmaceutical company. And so these advanced pharmacy practice experiences, we do have options to work in a pharmaceutical company. And then instead of going to a residency, many of our students went and did a fellowship at a pharmaceutical company. And if that is something that you do identify that you are interested in before starting pharmacy school, you can kind of target what pharmacy school you go to. For example, on the East Coast of the United States, there's a lot more pharmaceutical companies than on the West Coast. So near San Francisco, we only had about 2 or 3. The East Coast, there's a bunch. So there's much more opportunities to do industry rotations. So that's definitely something that you can also try and customize before you even enter pharmacy school. All right, so I'm going to move on to an example of what this sort of progressive learning looks like. So I'm going to use the first organ system or disease process that the students will learn about in their first year, being the cardiovascular system. So let's take the example of a myocardial infarction or a heart attack, as many people call it. So what the students would be doing at home when they initially start learning about the physiology of the cardiovascular system is learning about what a myocardial infarction is. So it is the clotting or the narrowing of your cardiac vessels. What signs and symptoms are typically correlated with different stages of coronary occlusion? So we know that we have angina, we know we have unstable angina, non-ST elevated myocardial infarctions, a complete occlusion when you have your ST elevated infarctions. And so what does that mean? So they learn about that all at home, which ones actually need intervention emergently and which ones might you medically manage. So that's all information that they can look up at home, they can learn. So then when they get to the classroom, then they review patient cases of a patient comes in and what do they describe? What does their chest pain feel like? Does it happen at rest? Does it happen when they are exerting themselves? What does their EKG look like? Do they have ST elevations? Do they have ST depressions? And what does that mean? And what about laboratories? You look at a patient's laboratories, you look at their troponin. What does a true troponin elevation tell you? And then they practice triaging patients. So do they think that the patient needs to go emergently to the catheterization lab, or do they think that they can monitor them and see if the occlusion progresses? So again, they learn the information at home and then they actually apply it when they're in the classroom in small team settings. And then when they go on to actually learn the medications that they would use to treat a myocardial infarction at home, they would learn about the different medications that they use emergently. So they learn about the heparin, the clopidogrel, the aspirin, things of that sort at home, and then learn about the long-term management. So after someone has a heart attack, what medications should they be on that have shown mortality benefit? So then in the classroom, they practice recommending these medications to their small group, or if it's the inquiry, they recommend them to the medical students. And then they actually learn about how to adjust different medications based on the long-term treatment goals of different patients. What do the labs look like 6 months down the road? Do they still need a high-dose statin? Maybe, maybe not. What are their vital signs? How do we monitor them? How do we reach the goal strength of the medications? And so they learn about how to prescribe medications in different patient populations in the classroom.
Your question, because this is very interesting. For example, about vital sign and labs and so on. The students are involved in practical activities that the students can touch the patient or not.
Oh, no, this is all on their computers. So they,
simulation.
yes. Except when they go to the APCS, which is the next level of progression, and that's when they can take the vital signs and they can be hands-on. But in the classroom, all of the laboratories are just on a computer. But you can see that early on in their training, they're clinically assessing the patient. So they're building those clinical skills right when they start pharmacy school. And then what would this look like in the last part of this block when they do their inquiry immersion, when they're actually working with the medical students? So the team of pharmacists and doctors will work on patient cases looking at patients who are having heart attacks in different social contexts, different economic contexts. Do we think that the patient should have a stent placed? Do we think that they're actually going to be adherent to their medications afterward, or is their stent going to just occlude right after they get the intervention? And that might be actually higher risk than if we didn't intervene. We look at different laws, different regulations, different health policies based on what hospital you're in. So a lot of different factors that they talk about within a team that they'll talk about in real life. So that's the example of kind of how that would look in the School of Pharmacy.
So your course is connected with many teachers, a lot of teachers, different multidisciplinary topics.
Yep.
Like me. It's not like it's the problem. And also in the course, for example, cardiovascular, we were connected ethicals, protocols, trials, activities, ethical committee role in
the same course. And the seminars in this collective discussion, all teachers, different teachers are involved in the discussion.
Yes.
Not only one.
No.
And do you use, for example, you told about Twitter method, yes, very interesting for the students. Così dovremmo fare anche noi, but for example, students as teachers and so on.
Are students teachers?
Yes.
So Giovanni had a couple great questions. His first one was whether or not multiple instructors teach the students. And yes, so for the myocardial infarction, it might have been an emergency medicine pharmacist that taught that because they're the ones that see it. Or say you have heart failure, we're talking about heart failure, then a pharmacist who specializes in heart failure would teach that class. Or if we're talking about heart transplant, then we would have a transplant pharmacist talking about that course. So whatever pharmacist is specialized in that disease state gives the lecture on that topic. I forgot your second question. I forgot. Yes. Oh, that is just me saying two different words. So our School of Pharmacy and University of Pharmacy is the same thing. Yes. Any questions from home? Can you hear me?
But the students are during the school, for example, in cardiovascular topic. The lectures will be the lectures made in the department, the cardiovascular department, or only in the teaching rooms of the university?
Oh, yes. So the lecture.
For example, in NICU, IEC.
Yeah, so the lectures are not real world. So the professor won't like walk around the ICU while they're teaching the lecture. They will be in their office. So the lecture is essentially the same sort of lecture that you guys would have. We just watch it at home versus in the lecture hall. And then Giovanni's other question that I forgot that I now remember is, during our lectures, are we learning about clinical trials? Are we learning about treatment protocols? And the answer is yes, especially in cardiology. Cardiology is great for clinical trials because they have large patient populations, so you can actually get true conclusions out of it, and you can see mortality benefit, and you can see what drug is actually superior. So yes, we learn about all of the pivotal trials that lead to why we prescribe certain medications, and then we also look at the treatment protocols for our institution.
Other questions? I have another question. But you spoke about simulation. Can you explain better which methods the simulation are you using? For example, Monash, my dispenser of Monash University, or other specific computer programs.
Oh, I see. Yes. So the question was,
what the students can do in this simulation problem.
Are you talking about the clinical practice, like the second level? Yes, I think so. The question was about our simulations. So when that like first stage of hands-on work. So what it looks like is the university hires actors, like true actors, to act like they are patients. And so they'll be sitting in an exam room. And so we have no idea why they are in the exam room. And so we go in and we have to figure out why they're there. So, hi, my name's Jenny. I am the pharmacist. Can you please tell me why you are here today? And they say, I have chest pain. And so I would have to continue asking things like, how severe is your chest pain? Does your chest pain radiate anywhere throughout your body? Does it happen all of the time? Is it more pain? Is it pressure? And so I have to determine if I think it's truly cardiac in nature. Do I think it could be heartburn? And based on what I think, then I have to write down what sort of testing or laboratories I would get. And then based on my most likely differential, I would then have to write down what medications I would use to treat the patient.
Do you use simulated standardized patients or not?
Yes.
Actors?
Yeah, we use actors.
Or students as actors?
No, we don't know who they are. They're actors.
Teachers.
No, they're like people out in the world that we don't know.
Actors from theater?
Yes. All right, moving on, but definitely feel free to ask me questions at the end if they pop up. All right, so yesterday, as I said, I talked about clinical care pharmacy in the hospital. So now I will talk about where clinical pharmacists work outside of the hospital. And we call these our ambulatory care clinical pharmacists. So where do they work? They work in different clinics around the hospital. So they work in clinics like our oncology clinic, our transplant clinic. We have an HIV clinic, so different specialty clinics around the hospital. They work in patient-centered medical homes, which I know that's not a common term used, so I will talk about that more in the next few slides. They work in just primary care physician offices. And like I said, they work in different specialty clinics, including anticoagulation clinics and geriatric clinics as well. And what their primary job is to really smooth or improve the transition of care for patients when they move from the hospital back home, and then also to just manage their medications long term. So continuously assess medications, making sure they are appropriate, making sure the patient still needs the medication, because obviously polypharmacy is a huge problem, especially in our geriatric population. And so that's where these pharmacists are located in their practice. And so they call it the embedded pharmacist model. And so this was a statement put out by our American Medical Association. And this is important because they really do recognize the pharmacist's position out in the community. And so they describe the embedding a pharmacist means to fully integrate them into the care team. Pharmacists work closely with the physicians and other members of the care team, and they may also see their own patients. Clinical pharmacists are trained to help manage chronic diseases and are experts in medication management and in identifying barriers to medication adherence. So oftentimes, physicians will ask about what medications a patient is taking, but I very rarely hear physicians ask how you're taking your medications. Do you take them every day? When's the last time you missed one of your medications? And so that's a big area of medication management that is often missed when a pharmacist isn't present out in the community. And so where this model came about is you heard physicians say things like, I shouldn't spend as much time on my patients and their paperwork. I should be more at the bedside. I wish we could use our team more effectively. I wish delivering quality care really takes a coordinated effort from every member of the healthcare team. And so pharmacists are within these teams in the community to really help provide value-based and patient-centered care. So we know how to cost effectively use the most appropriate medications. We again ask about medication adherence, which is critical for patient safety as well as appropriately treating different conditions. We are able to coordinate medication use across settings. So we're able to see if the patient can afford their medications. Are they picking up their medications? Do they actually have a ride to the pharmacy? And we know that the pharmacist's salary is less than the physician's salary, and so they can provide a lot of the same services as a physician at a much lower cost, which saves our health system money. But not only that, we have a lot more patients that need medical care these days as our population ages, and we have a shortage of physicians. And so we need another member of the healthcare team to see these patients. And that's kind of where the pharmacist is stepping in this clinical pharmacy stage. So I talked about a patient-centered medical home. So what is that? So it's a patient-centered, as is in the name. It is physician-led. It is meant to be cost-effective, and it takes care of the patient long-term. And so they build relationships with the team, which is a team of healthcare providers, and the end goal is to keep patients out of the hospital and healthy at home. So this is an example of what a patient-centered medical home would look like, say for a patient who has kidney disease. So typically, if you think about a patient who is on dialysis because of kidney disease, their main provider is their nephrologist. But they need more than just a nephrologist to look at their care holistically, so their entire care, not just their kidneys. And so this patient, as part of their medical home, would have a general practitioner, a nurse coordinator, a health promoter. Oftentimes in the medical home, this is like a dietitian, someone who looks at their health outside of just medications, and then the pharmacist. So within this specific medical home, the nephrologist and the health promoter would see the patient every single week when they're at their dialysis appointment. And then the general practitioner and the pharmacist would see the patient every other week to discuss how they're taking their medications. Are there new medications? Do their medications are they still as appropriate as possible? So this healthcare team is continuously visiting with the patient and discussing the care together. So it's really just coordinating care. So when I talk about this model, does this sound similar to anything that I talked about yesterday?
There is a conflict with the role of the doctors.
No, so the nephrologist will still continue to focus on the kidney disease. The general physician will focus on the patient's health overall. Because in your aging population, it's pretty rare to just have kidney disease, and so you might have hypertension, you might have high cholesterol, you might have had a stroke. And so the general physician will look at all of the other things in addition to working with the nephrologist. So this looks, oh, yes, what does this sound like? So this looks a lot like what I've talked about yesterday on the inpatient side. So the care team that works together in the hospital looks a lot like the care team that is now working together in the community. And so in the United States, we're really recognizing that independent of where the patient is, the best care that we can give them is in a team-based setting where we're really leaning on the expertise of each medical professional. And this is where your ambulatory care clinical pharmacist works. And so what is the role of the pharmacist in this team? It's really looking at, again, the appropriateness of every medication, the effectiveness, the safety, and the big part is the adherence. Because unlike in the hospital, when the nurses are giving the medications, we know that the patient is hopefully taking them and not like spitting them out. But at home, we don't know what they're doing. And so continuously looking at adherence is important. And they develop personal medication care plans for each patient. They do medication histories, medication reconciliations all of the time. And they ask the patient, what is your therapy goal? So think about a patient with hypertension. We have specific blood pressure goals for patients. However, what if your blood pressure goal isn't appropriate for your patient because every time they stand up, they get dizzy? Well, you need to individualize different goals for your medications, and that's what the pharmacist helps to do. And then after they talk to the patient, they always communicate back their concerns, any medication changes back to the care team, as well as to the family. So there's continuous communication with both the patient, the family, and the other providers of the care team.
One question.
Mm-hmm.
This activity is connected with the GP or the specific doctor specialists about drugs, appropriateness, and so on.
Mm-hmm.
Yes, but because in Italy all these activities are in the GP or hospital doctors. How can you work with the doctor? The doctor decide, you can suggest, or this is a role specific for the pharmacist, and the doctor
Disagrees.
must accept or can accept.
Yeah. So Giovanni had a good question. So if the pharmacist has a recommendation for, say, a medication change, does that just happen? Does the physician have to accept it? How independently can the pharmacist be? And we'll talk about that in a few slides because that's most people's questions. But kind of how this works is that once every 2 weeks, the entire care team meets independent of the patient. And so they meet and talk about all of their patients. And so that's how information is communicated between the entire care team. It's not like, well, I talked to the nephrologist about this. I talked to the care coordinator about this. Everyone hears all of the same information, so they know all of the things about their patients.
For example, on one comment about what is happening in one hospital in Italy. In Turin, Professor Casco, the director of hospital pharmacy of Valuebased, has 2 pharmacists in each wards. They collaborate with the doctors about competitiveness and so adherence and so on about the drugs. And at the end, when they dismiss the patient, they collaborate in writing the letters specifying why drugs, which drugs has been changed and why. And they control the patients for 7 days at home.
Interesting.
I think it's the same in USA.
No. So Giovanni said when patients leave the hospital, the team that cared for the patient in the hospital continues to own their care for 7 days after discharge. That is not the case in the United States, and that's why these teams of providers in the community setting are so important to ensure that smooth transition back home, because once they're discharged, the hospital providers are done. And so that's why it's very important to have that communication with the inpatient team, the hospital team, to the community team. And so typically we will ask when you are admitted to the hospital who your outpatient provider is, so that the hospital information can then be electronically sent to the community team so that they can pick up the patient's care as soon as they're discharged. So how do the pharmacists do this? What do the pharmacists actually do in this medical home? And how do they identify medication problems? So the pharmacists can obviously not help manage every single patient, and so they really identify the patients that are not achieving the clinical goals on the medications that they're on. And so they understand the patient's personal medication experience, their history, their preferences. So maybe a patient's not on a medication because they didn't tolerate it in the past. So they take the time to sit down with the patient and discuss what they've tried in the past, what has been effective, and what the goals for the patient are. During that conversation, they identify what medications the patient is taking, and again, how they are taking them. So are the medications just not working because the patient misses half of the doses that they're supposed to be taking? And then when they're doing that medication history, they're assessing the appropriateness of each medication and the effectiveness. And they're identifying any drug therapy problems that might exist. And then after they understand all of the medications, they understand why the patients are taking them, maybe why they're not taking them, then they develop a care plan that addresses the recommended steps and what changes to the medications that they think will really help the patient achieve the outcomes that the providers would like them to. During that meeting, they discuss this with the patient. The patient is always aware of what the pharmacist is going to be recommending to the care team. The pharmacist documents all of their thoughts and opinions in the patient care record so that, again, the entire care team can see what was discussed and what their thoughts are. And then they frequently follow back up with a patient. Again, in most models, it's every 2 weeks to see how they're doing and if further changes to the medications need to be done. So that's the clinical pharmacist role in the medical home. All right, so here's an example of a patient that might have kidney disease and they might be within this medical home. And so again, they have a general provider, they have a health promoter, likely a dietitian, they have the nephrologist, a pharmacist, and then a nurse coordinator. So our patient is a 35-year-old male. He has chronic kidney disease, stage 3, secondary to uncontrolled hypertension and diabetes. And he is part of this medical home program because he really wants to optimize his medical therapy because he does not want to start dialysis sooner than he needs to. The history of his present illness, the patient meets with the care team because he's not been feeling well over the last few days. He has nausea, dizziness, and fatigue. And because of this, he hasn't been eating or drinking very well the last few days. Being the amazing pharmacist that you are, you immediately ask him for his medication list. This is what he's on. So he's on hydralazine and amlodipine and atenolol for his blood pressure, and lisinopril. He's on metformin. He does have a high A1C. He should be on insulin, but he is refusing to use insulin. And then he's on sevelamer carbonate for his potassium levels. All right, so what is your differential for this patient? It can be pretty broad because, again, he's just coming in, he's not feeling very well, he's not eating and drinking very much. So it's a very broad question. Your patient isn't feeling well, he's nauseous, he's throwing up. What might be wrong with him? Have what? Blood pressure? Sure. We know he has hypertension. Maybe his blood pressure is too low, so he's not feeling well. Could be. All right. I'll help you out on this one because it's a wide differential. So what would you want to order on your patient? What sort of things might help you narrow down what could be going on? What tests? So are there any labs that you'd want to get? Sure, yeah. So just general, basic metabolic panel, look at his electrolytes, things of that sort, get some vital signs. He's been feeling dizzy. Maybe he might be, his blood pressure might be low. So yeah, just a broad workup would be appropriate for this patient. All right, so looking at his vitals, we see that his heart rate is low. So it's in the 50s. And he's a bit symptomatic from it because he is dizzy. His respiratory rate's fine. His blood pressure is still okay. So even though his heart rate is low, he's still maintaining his blood pressure. Looking at his labs, his potassium is high. It's 5.8. His creatinine is elevated. So his baseline creatinine is 1.7. It's now 2.6. So that's quite a bit higher. He's acidotic, his pH is 7.2, and he has an anion gap of 16. So if there's any, let's say, medical students listening in, what could the patient have if their pH is low, they have an anion gap? What might you be thinking? His glucose is elevated, but again, he has diabetes. This is actually pretty good for him, he says. Usually it's in the 200s. All right, so my initial thought, and let's say it's what the care team thought, they thought, well, maybe he is in diabetic ketoacidosis. His glucose is a little elevated, he's acidotic, he has an anion gap. However, you can see that his urine ketones were negative, so likely doesn't have DKA. But he's not feeling well. He looks very sick at this point. So being the good pharmacist on the team that you are, you say, okay, this might be medication related. So let me look at his medication list and see if there's anything that might be contributing to it. Do you guys see any medications on here that might, in someone whose renal function is worsening? So we think maybe there's a medication that is building up in his system and could be causing him to be acidotic with an anion gap.
Metformin.
Yes, exactly. So we know that metformin can cause lactic acidosis because it's cleared by the kidneys. And so when when his kidney function is worse, it's not clearing, and so it's building up in the body. And when you have high levels of metformin, it inhibits this enzyme called pyruvate carboxylase. Oh, sorry. Let me move that. So it inhibits this enzyme called pyruvate carboxylase, which typically your pyruvate goes into glucose and is excreted. However, when this enzyme is inhibited, your pyruvate is turned into lactate. So then you get lactic acidosis. And so this is something that typically only a pharmacist would think about. And so you're like, okay, well, he might have a low pH and an anion gap because he has a high lactate due to metformin. So let's get a lactate. So you do, oh, and the clinical features of the metformin-associated lactic acidosis are typically nausea, vomiting, diarrhea, not eating well, so very similar to what your patient has. So you get a lactate and it's 12, so very high. And you will see if you do have metformin-associated lactic acidosis, you're not really looking at lactates of like 2 or 3. They're usually 8 or above, so very high, and it can cause people to become very sick. All right, so now you're very proud of yourself because you helped diagnose this patient because of your knowledge of medications and how medications could become toxic when organ function is worsening. So what would your medication recommendations be for this patient? So this is the great part of working on the clinical team is you not only can help identify the problem, but you can also tell them what to do. All right, so what I would do, I would say, because I know his renal function is not good, I know that his potassium is high, I would hold his ACE inhibitor. I would hold his lisinopril because we know that increases potassium. I would hold his atenolol because I also know that atenolol is cleared by the kidneys as well, and we know that his heart rate is low, probably because he's getting a high level of atenolol in his body. Obviously, I would hold his metformin because he's experiencing lactic acidosis that's making him quite sick from his metformin. And because his potassium is high, it's 5.8. I don't know about his EKG at this time. He may or may not have EKG changes, but I would start some sort of hyperkalemia treatment on this patient. So those are the recommendations that me as the clinical pharmacist would make to the team. So where do you think this patient should go? Should I tell him to hold some of his medications and then he can go home and we can follow up with him next week? Would you admit him to the hospital? Hospital, yeah. So this would be a patient who I would admit to the hospital because we want to improve his kidney function before he goes home. So he likely needs hydration because he hasn't been eating or drinking very well. We want to continue monitoring his blood pressure since we did just stop his lisinopril and his atenolol. So we might need to add a different blood pressure medication until his kidneys get better. And then because he is diabetic, we also might need to start some sort of insulin in the hospital since we cannot use his metformin. And we want to see his potassium come down to an appropriate level. All right, any questions about that, kind of how a pharmacist contributes to the diagnosis of a patient based on their knowledge of medications and how they would make recommendations to the patient's therapy plan? Do the doctors know? Yes, so if I were to say I think we should give hyperkalemia, high potassium treatment, they would know what to do. They wouldn't need to wait because we are together talking about it. So the pharmacist, that's the beauty of the pharmacist always being there, is that they don't have to wait for us to recommend something. We're just continuously talking about it. One thing that they sometimes need our recommendation for hyperkalemia treatment is we either use 10 units of insulin or 5 units of insulin in patients with poor renal function. 10 units often causes a lot of hypoglycemia, and so we always recommend 5 units, but they're always used to ordering 10. So that's an intervention that we often will make. All right. Let's see, so what patients benefit most from ambulatory care pharmacists? So again, it's really those patients who have not reached or are maintaining their intended drug therapy. So they're not reaching the blood pressure goals, they're not reaching the goals for their cholesterol, maybe they're not reaching their goals for their depression. It can be many, many different clinical goals, and the pharmacist assesses the goals for each medication during each visit. Those who experience adverse effects from their medications. So patients are, I've found, much more willing to talk about, I started this new medication and it's not making me feel good, than they are potentially with other care providers. And so they're able to make recommendations about that. Those who have difficulty understanding and following medication regimens. So I mentioned yesterday, we frequently make charts of medications and we tell them what exact time of the day they should take each medication. And we make the chart in the language that they speak. And so we try to help with literacy. If they have poor literacy, we put the photo of the pill instead of the name of the medication so that we know that they know what medications they should be taking at what time of the day. And we also do preventative care. Ambulatory pharmacists are very focused on preventative care. So they give vaccines, they make sure all the patients are up to date on different visits for preventative care. So that's a very unique thing for these clinical pharmacists. And then those who are frequently readmitted to the hospital. So this is really where we save money in managing the patient at home versus if they're continuously admitted to the hospital. So this is something that's a big goal for these medical homes. All right, so how can a clinical pharmacist benefit my practice? So that's a question for the physician. So they work with physicians to optimize the drug therapy and achieve clinical outcomes. They improve patient and care team education. So pharmacists are, I would say, better able to communicate about medications with the patients. And so patients really benefit in understanding their medications. And when they understand their medications more, they're more willing to take them. So we found that putting a pharmacist in the care team does increase adherence because the patients understand why they're taking their medications. And they can streamline refills, and oftentimes pharmacists will set up medication delivery for their patients. They will, the nurse that's part of the care team will go to the patient's house and fill their pill box for them. So a lot of different services to help the patient take their medications. And they provide effective, higher quality team-based care that also resembles the hospital setting, but now out in the community. So how do pharmacists do this? So this gets to Giovanni's question of, can pharmacists just prescribe new medications on their own? Do they have to talk to the doctor before providing these recommendations, say, to the patients? So we have what are called collaborative drug therapy management protocols. So these are protocols the physician and pharmacist have to voluntarily agree to work together under different protocols. So even if you work in this medical home, you don't have to have collaborative drug therapy management, but it does move some of the clinical tasks from the physician to the pharmacist. And so we have these protocols that are disease state specific. And so say you are managing hypertension. So the physician might decide, I have a lot of trust in my pharmacist, or no, that's not a good example. Yeah, it's a good example. And they say, okay, I'm going to meet with the patient the first time that we meet them. As a group, we're gonna decide what the best medication is for the patient, but all the subsequent visits, you the pharmacist, you can meet with the patient. And based on whether or not they've reached their goals, you can adjust the medication how you think. So a lot of the protocols are that the physician has to do the initial prescribing, but then the pharmacist is able to make any sort of adjustments down the line, and they're able to order laboratories that are medication related. So say the patient is on warfarin, the pharmacist can order an INR. The patient is on digoxin, the pharmacist can order a digoxin level and adjust therapy based on what comes back. So they have a lot of more clinical tasks and are able to adjust medications without talking to the physician under these management protocols.
This is only in hospitals or also in community?
This is only in community, not in the hospital. We do have delegation protocols in the hospital, but they're different. These are just the community ones. And so under the therapy management protocols, the pharmacist is able to assess the patient independently. Like I said, order drug-related labs. So we can't order any laboratory that we want. It has to be a reason because we want to see if the medication is appropriate. They administer vaccines. They're able to select, initiate, monitor, and adjust drug regimens. Most time they are only able to monitor and adjust, but there are certain states where they can initially select them. And then sometimes you can also order refills of medications, and usually it's on chronic medications that the patient has been on for an amount of time. However, these collaborative drug therapy management protocols, they do not give the pharmacist provider status. So we can't just prescribe any medication that we think is appropriate to our patients. However, that is the goal of the ambulatory care clinical pharmacist, because achieving provider status will give patients consistent access to care that improves the safety, quality, and outcomes, and also decreases cost of their medications. We know that a lot of patients got access to medical care in 2014 especially in the US under Obamacare. So there's a lot more patients that are wanting to see medical professionals these days. And by 2025, we need 40,000 more primary care physicians than we have. And I can tell you that more physicians are not going into primary care. And we have an aging population, so a lot more patients need doctors. And pharmacists represent the third highest number of licensed professionals in the medical field, and we are the only drug experts. So we fill that needed space of a medical professional. And acknowledging pharmacists as non-physician providers under the Social Security Act allows us the autonomy to provide the care and optimize therapy independently. So again, we increase access to not only all patients, but underserved areas. In a lot of our underserved areas in our rural populations, there's not a lot of physicians. So kind of like I was talking about yesterday when I was talking about our pharmacy extenders that can go do the work just as good as we can, but we don't have enough pharmacists to do it. We could be the physician extenders. We could fill that patient care need for the physicians and do the tasks, not all of the tasks, but a lot of the tasks just as well. And if we are considered providers, we can also get paid by our insurance companies for performing the services. Currently, pharmacists cannot bill for the services that they perform within these medical homes, and so we have to be supported by the physician groups, and that's often why we can't expand this area of pharmacy, but we could if we had provider status. So we are continuously advocating for the US to obtain provider status, and we're getting closer and closer with all of these collaborative practice agreements and showing people that we can independently function as a provider for many patients, but we're not there yet. So that's kind of where I see this field of pharmacy going. All right, so that is my spiel on ambulatory care pharmacy practice and how the benefits of the pharmacist, how the pharmacist does it, and kind of their place within the medical team. I have one last patient case that will kind of go through what a pharmacist would do in an anticoagulation case. But does anyone have any questions about that field of pharmacy overall? Yeah, so the question was, say a medication, say digoxin, like we were talking about, the digoxin level comes back at 2, which you know is much higher than you want for both heart failure and atrial fibrillation. Can the pharmacist independently reduce the dose of medication based on the laboratory? And the answer is yes, if they have one of those collaborative practice agreements with the physician. If the physician has trust in their pharmacist and they say, okay, for atrial fibrillation or heart failure, our pharmacist is able to adjust all of the medications based on the laboratories. And so in that case, they would be able to. Any other questions?
Is the pharmacist in USA a prescriber like in UK?
No. The question was, are the pharmacists in the United States prescribers like they are in the UK? And no, so that's where we're trying to go. We're trying to have the designation as prescribers or providers, but we do not yet. All right, so moving on to our last patient case. So you have a patient, he is a 68-year-old male who presents with his wife to the emergency department with difficulty urinating. So he feels like he has to urinate, but he's unable to. Sometimes when he's able to, it is painful. His wife states that this has been progressing over the last 3 days. What questions do you want to ask the wife or the patient? Yeah, so great responses here. The first one was ask the patient if he's drinking. So is he not urinating just because he is dehydrated? Is he drinking a lot and he's still not able to urinate? Because then maybe that's more of an obstructive process. Another comment was maybe his renal function is declining. Maybe he has an acute kidney injury and he's not able to urinate for that reason. Yeah, is this your brother? We have a urologist in the classroom. Yes, so maybe he might have prostate disease. Very good. I'm glad you're here. Mm-hmm. Yeah. Mm-hmm. Yeah. So the comment was, ask him if, when he's able to urinate, is there blood in the urine? Because I have spoiled that this is an anticoagulation case. So maybe that could clue you in on something, or maybe he has like a stone in his ureter or his kidneys, and maybe there's blood, and that would clue you to, again, maybe it's some sort of obstructive process, or maybe there's damage going on. So all really good questions. All right, so you asked about his past medical history. He has prostate cancer, he has AFib, he has hypertension, he has heart failure, he has prostatic hypertension, he has iron deficiency anemia, and thankfully he has no medication allergies. So what's his past surgical history? He had a partial prostatectomy 2 weeks prior, and he's had several ablations in the past for his atrial fibrillation. They have not been successful, but he has had those. His home medications, so he takes lisinopril for his hypertension. For his AFib, he takes amiodarone, digoxin, metoprolol. He is on warfarin. For his BPH, he takes finasteride and tamsulosin, and he takes an iron supplement for his anemia. Do you guys think this is a pretty common patient, pretty common medication list? I think so. All right, so what's on your differential? He had a recent partial prostatectomy 2 weeks ago. He's having trouble urinating. It is painful. Anyone can answer. All right. So I'm gonna, well, okay, what would you want to order to help you decide?
I don't know how to say that. It's like
Oh, sure. Yeah, you could definitely order like a bladder ultrasound. You could order a kidney ultrasound. Maybe he has some hydronephrosis that's causing him not to urinate. So imaging, very important. What about laboratories?
maybe I don't know. I don't know, but upload the test or see some values because I read his doctor, a surgeon.
Mm-hmm. A what? A kidney function test? Yeah. So looking at his creatinine, seeing if he does have an acute kidney injury, and that's why maybe he's not urinating. Good. All right, so we did those things. So his heart rate is normal. He's in atrial fibrillation like he always is. His blood pressure is fine. Looking at his labs, so he does have a kidney injury. His creatinine is 2.2. It's typically about 1.3. His INR is 2.6, which is in the goal range for him at 2 to 3. So everything looks good, essentially except for his renal function. So you get a urine analysis because you do know that it is painful when he urinates. He does have a lot of white blood cells. He has positive leukesterases. So I would probably consider this a urinary tract infection. However, when you palpate his prostate, he also endorses a lot of pain with that. And so I'm sure our urologist was thinking about this, but your most likely diagnosis is bacterial prostatitis. And so what this is when your patient has a urinary tract infection, or in his case, he might have actually gotten it from his surgery. But if in the case of a urinary tract infection, it migrates up to the prostate and infects that as well. It can be very painful for the male patients. And so how do we diagnose it? So it's very similar kind of presentation to urinary tract infections, but instead of having frequency with urination, sometimes like our patient does, you have difficulty urinating. And you do want to get a culture to see what could potentially be the infection. The most likely pathogens do mirror those of a typical urinary tract infection, typically your enteric gram-negative rods like E. coli, Klebsiella, potentially Enterococcus. Enterococcus typically doesn't actually cause urinary tract infections, but it could in your surgical patient. In patients who have recent manipulation, like our patient, Pseudomonas could be a causative agent. And sometimes this happens due to sexually transmitted diseases. So in our young male population, probably not this patient since he is older and happily married, but it could be caused by Neisseria or chlamydia. So what are our treatments for prostatitis? If you are worried about potentially being a sexually transmitted infection and you want to cover Neisseria and chlamydia, we would do our ceftriaxone 1 dose and then followed by doxycycline. However, in our patient, since that's not what we're worried about, and he did have recent manipulation, so we probably do want to cover Pseudomonas, you can either use ciprofloxacin or levofloxacin. Bactrim is on there, but it's not recommended if you truly want to cover Pseudomonas because it does not cover Pseudomonas. So those are the treatment durations. So what would you recommend for your patient? So we've decided he actually has a bacterial infection, right? So he has prostatitis. So how would you want to treat that? Antibiotic. So based on our guideline recommendations, and this is where you need to look at the guideline recommendations and then look at your patient. So which antibiotic is most appropriate based on your patient's history? So since our patient recently had a prostatectomy, that puts him at risk of having Pseudomonas as the causative organism. And so out of all of our options, you would look at the bottom box, and the ciprofloxacin and levofloxacin are the only 2 oral antibiotics that cover Pseudomonas. So you could choose either one, ciprofloxacin or levofloxacin. Typically for urinary tract infections, we will choose ciprofloxacin. And then what would your dispo for the patient be? Is this a patient that you think we can likely send home on an oral antibiotic, or is this a patient that you think needs admission? So this is a patient that we would probably send home, right? He doesn't really have signs of systemic infection. He's not hypotensive. He's not febrile. He likely just has bacterial prostatitis, which we can treat with an oral antibiotic. So that's what we do. So we prescribe 500. Why what? Oh, sure. So the question was, why would you choose ciprofloxacin and not levofloxacin? And you could have chosen either. You just have to choose. And I chose ciprofloxacin. But yes, you could definitely choose levofloxacin. Okay, so we prescribe ciprofloxacin 500 milligrams orally twice a day. And you tell the patient, I think you can go home. I don't think you need to be admitted to the hospital, but please return to the emergency department if your symptoms do not improve. So following discharge, because you have a really great transitions of care program, the patient's anticoagulation clinic gets sent the discharge paperwork so that they see what happened in the hospital. And so you are the pharmacist, the ambulatory care clinical pharmacist working at the anticoagulation clinic. You read through the discharge paperwork. You're like, okay, so he has prostatitis. He got a urine culture. We don't know what grew yet. He had reduced kidney function, and he was prescribed ciprofloxacin. Do you have any thoughts? Would you have any thoughts as the pharmacist on if that was appropriate? Is there anything that you would change? All right, so this is what I would do. I think that there's 3 big problems with what happened. I think that there's several drug-drug interactions that are important for our patient. We know that he's on warfarin for atrial fibrillation. We know that his INR was 2.6, so it is at the higher end of his goal range. And we know that ciprofloxacin actually inhibits the metabolism of warfarin. And so when you put the 2 together, you most certainly get increases in your INR. And so when you do prescribe these 2 medications together, you need to be a lot more, you need to check the INR much more frequently. And so being the anticoagulation pharmacist, that was the first thing you thought about because that's your specialty. But then you also know that the patient is on amiodarone for their atrial fibrillation. And you know that both of amiodarone and ciprofloxacin can prolong the QTC and put the patient at risk for something like torsades, which is a fatal arrhythmia. And so you're like, well, they didn't send me what the patient's EKG looked like. Maybe their QTC was already over 500, and this could be a potentially fatal drug-drug interaction. And you know that the patient had a creatinine of 2.2, so much higher than their baseline. You know that both ciprofloxacin is cleared by the kidneys and their digoxin is cleared by the kidneys. The emergency medicine doctor didn't get a digoxin level, and so my recommendations are, okay, what would you do? Knowing that these drug-drug interactions exist, these medications are cleared by the kidneys, his kidneys aren't doing very well, what would you recommend to your team? All right, this is what I would recommend. I would have the patient come to the anticoagulation clinic tomorrow, and then in 3 days again to get repeat INRs to make sure that they're not too high. I would have them get an EKG when they came back to make sure the amiodarone and the ciprofloxacin combination wasn't prolonging the QTC. And I would also get a digoxin level to make sure it's not too high, as it's likely not being cleared as much by the kidneys. I also know that ciprofloxacin should not be dosed twice a day in a patient with his current renal function. So I would tell them to decrease the dose to once daily. And then I also know that the patient has a bacterial infection, the patient got a culture. I don't know if the antibiotic prescribed is actually covering the bacteria. So I would put on my to-do list to follow up the patient's urine culture. So I come up with all of the things that I want to do, and I talk to my care team about them, make sure that everyone is in agreement. I then call the patient and tell them that I would like them to come back for these reasons, and then I would adjust the medications, right now just the ciprofloxacin since I don't have any of the other data, but tell the patient to only take it once a day. So then, yes, so this is a tough situation that we frequently get into. All of the fluoroquinolones will have the QTC prolongation and the interaction with warfarin. So if you truly need to use something that covers Pseudomonas, and you definitely can't use one of those two, the patient has to be admitted for a different antibiotic. And that's why in this case, my recommendation wasn't just, well, why don't we just switch the ciprofloxacin to, say, cefuroxime or something, because I still want to cover the Pseudomonas. I just think that I can monitor the patient and continue the therapy that they're currently on. And so I follow up the urine culture as I told myself I would. So we know from our urine culture that E. coli has grown, and we can see that it is fully susceptible to all antibiotics. Incredibly rare. The patient obviously hasn't traveled very much. What would you do with this information? So your two choices are, would I keep the patient on the ciprofloxacin and deal with the QTC, the INR? Is the risk versus benefit better to keep the patient on ciprofloxacin? Or could we change them to any of these other antibiotics that would have less risk for the patient? Yeah, so I would change the antibiotic for the patient, probably to a cephalosporin, because you don't have any of those interactions. I would call the patient, let them know send the prescription to the pharmacy, and then the patient likely doesn't even have to come back for any of the monitoring that I just told them to come back for. But what if this is your urine culture? So we see that it's completely resistant to your fluoroquinolones. It's essentially resistant to every single oral antibiotic that you could prescribe. What would you do in this case? It's easy. You have to tell the patient to come back into the hospital for intravenous antibiotics. Yep. So this is a case where the patient simply just cannot be treated in the outpatient setting with oral antibiotics, so they'd have to be admitted to complete different therapy. All right, so that was a pretty complex case to just show you how potentially patients from the emergency department, it looked simple. They had prostatitis, they got an antibiotic, they got sent home. Say there wasn't an amazing emergency medicine pharmacist to review that, but there were so many problems with that one simple medication that could put the patient at risk of bleeding, a deadly arrhythmia. And so that's why an ambulatory care pharmacist is so important to review the medications from when the patient goes from the hospital back out into the community. So really they're essential, both for that reason, for transitions of care, but also just for the long-term management of the patients so that they can stay out of the hospital, making sure their medications are as effective as possible and as safe as possible while they're still at home, and that they are still taking their medications. And it's best done within this complete care team. So that is the end of my presentation. What questions can I answer? Anything about the pharmacy school curriculum from the first part of the talk, or anything about the clinical pharmacist practice in the community setting? I hope you kind of saw how it does resemble the hospital setting, in that you're working within this care team and consistently evaluating the patient. No, it's not every day like you would be doing in the hospital, but it's every couple weeks, and that's what's most important, so that you can keep changing the medication as you need to. All right.
Please, question.
So you can treat patients independently because of those collaborative practice agreements. So it's actually in writing for different disease states what the physician said you can do on your own. It is still under their license. They sign it that you can do this, but under their license. And so that's how you can work independently. You can't work independently all of the time. It's just whatever they have decided they think is safe for you to do. Versus, like we talked about, if we had provider status, then we could do it all independently and not have these like practice agreements. So technically it would still be on the pharmacist, but that's why it's important to, at the end of each day, the pharmacist and physician meet and talk about what changes were made. They don't do it in real time because then essentially you wouldn't be doing anything independently. But at the end of the day, you talk about the patients and what changes were made. So hopefully if they didn't agree with something that you did, then you could switch it before any like bad things happened. But so throughout the day, you're likely independent, and then you kind of come together as the team at the end of the day to discuss everything. All right.
Io non vedo domande. Se qualcuno ti fa la domanda,
Oh,
in the chat.
I don't know where the remote is.
Io non la vedo. I think should be important to know more about the practical activities. For example, we now we have a new curriculum in pharmacy from last week.
Oh,
Very recent.
yes.
And in this new curriculum for pharmacists, the clinical activity is mandatory at this moment. In the past, not. We are organizing some activities. One is theoretical information about clinical pharmacy. Another is activities related to the labs test in point of care that the students, that the pharmacists can do in their pharmacy. Probably also from pharmacists in hospitals. I don't know if the pharmacist in hospital can do exams or can order exams. And for example, glycemia and blood pressure, electrocardiograms, and so on. And then we experiment activities on the country, on the community, with screening of population about this topic, and especially related to the frailty, to the dementia, to the gait analysis, to the performance, general performance, to the dependency, it's okay?
Independent.
Dependent or independent people, and also related to the wellness, okay, wellness, okay. Is the same in USA? Do you do with students these practical activities in hospitals and in the country, in the community?
Yeah, so.
Can you explain? No, because this is important, because, for example, I read that one university in USA is organizing a specific dementia pharmacist group for students in pharmacy to address attention to patients with dementia. Because probably a pharmacist can perform some tests for dementia in the community. It's okay. It's can you explain better?
Yes, so when students go on both of their introductory pharmacy practice experiences, which would be at UCSF the first and second year, and more so during their advanced pharmacy practice experience, which is all of the third year. So I'll give myself, for example. So I did most of my rotations in the hospital on different wards. And so say I was in the intensive care unit. Typically in our intensive care units, we have two different medical teams, just because there's so many patients. And so the pharmacist who I was working with would be the pharmacist on one team, and I would be the pharmacist on the other team. So before my day started, I would look at all of my patients in their medical records, and I would see, did any of their vital signs change overnight? Did any of their laboratories come back abnormal this morning? Did any of their medication doses change? Say they had as needed pain medications. How many doses did they get overnight? Are they still in pain? So what medication changes would I recommend to my team for that day? So I would clinically, as a pharmacy student, look at my patient as a whole, and then before I went on rounds with my medical team, I would sit down with the pharmacist, review all of my patients, tell her what my medication recommendations are going to be, and then she would, the ones that she said, okay, that sounds good, then I would tell them to the medical team. So it was very hands-on. We were clinically assessing all of our patients as we were as pharmacy students. Not allowed to do? Yeah, yeah, I mean, we're not allowed to, so, for example, I talked about the collaborative protocols in the community setting. So Giovanni asked if we have those in the hospital setting as well. I think a good example of this is patients who are, say, on warfarin and have like a head bleed. And so we want to reverse the anticoagulation. So the provider puts in an order that is always 1,500 units, always. But we know that we base Kcentra or four-factor PCC on the units of factor 9. And so each box of PCC has different units of factor 9. So the emergency medicine pharmacist goes and we grab 3 boxes, we calculate how many units, and then we change the order. But we know that if your patient has a head bleed, your INR goal is less than 1.2. But the 3 boxes don't always get you there. And so we are under protocol able, after the first dose is given, to order a repeat INR. If the repeat INR is still above 1.2, we are able to then order more Kcentra and give it to the patient. So they did the initial order, and then we are allowed to do the laboratory testing and then giving more afterward if needed.
Is a personal interest. Which is the difference between the pharmacist and the technician?
The technician? That's a good question. So her question was, what's the difference between a pharmacist and a pharmacy technician? Are you talking about in like the outpatient or inpatient? Like in the hospital or in the community? Either. So pharmacy technicians in the hospital their primary jobs are to get medications where they need to be. So they work in our central pharmacy and they make medications. So pharmacy technicians are the ones that are making our sterile intravenous medications. Pharmacists don't make any medications. Our technicians do that. When a medication order goes to our pharmacy, they are the ones to grab the medication, put it in a bag with the label, and then they give it to the pharmacist just to verify. And then the technicians are the ones that take all the medications and bring them to the patients on the floor. So their primary job is for medication distribution. And I think it's essentially the same in the community. They fill the medication orders, they give them to the patients. They don't do any of the sort of medication counseling. They aren't part of the medical team. They just kind of help us get the medications to where they need to be. Really good questions. Anything else? All right, well, it's been an honor spending all this time with you guys and teaching you about our practice in the United States, and I'm really hoping to have some of you come to Boston in the future and see what we do in person. But thank you so much. This was great.
Do you have other, but I think we have many other questions because it is important to know, sorry, one moment, it is important to know what is the better way to prepare our students for clinical pharmacy. This is my interest because I know that some students are also interested in become researchers or work in pharmaceutical company or do other project delivery, discovery, drugs and so on, and so, tecnica, si chiama farmacologia tecnologica, yes, similar topics, okay. But about the activity for clinical pharmacist, this is a specialty. This is related to general work of the pharmacist, or do you have specialization after the medical degree, or during the medical after pharmacist degree, or during the course for interested topics, emergency, geriatrics, cardiology, surgery, and so on?
Yes, so
because clinical pharmacy is all.
Right. Yeah, so the term clinical pharmacy essentially just means that the pharmacist understands disease states. We understand how to assess labs. We understand how to not look at imaging, but like read the radiologist's report. We understand how to monitor clinical status based on what therapies we're giving and how we should adjust them. So it's more of just like we're able to see the patient as a whole and understand different conditions. So yes, so within clinical pharmacy, we have all of the different specialties like emergency medicine, oncology, transplant. And so, yes, our training starts early in getting exposure to different specialties. So during your first year of pharmacy school, your introductory pharmacy experience is always in the community setting. So it's like your pharmacies, and so you could be at a large retail pharmacy or like an independent. And I think the comparison here is your pharmacies in cities versus countryside, but they essentially do the same thing. And then the second year of pharmacy school, you're in the hospital. And so you can choose what ward you want to go to. So I obviously chose the emergency department. And then for my advanced pharmacy practice experiences, like I said, you can rank in order your which ones you want to do. You get most of the ones you want to do, not all of them. So I was actually doing that year at a different hospital, and so I chose the emergency department again. So in my pharmacy school training, I got to spend a month in 2 different emergency departments, which is pretty unique as a pharmacy student. So then when I entered residency, I was sure that I wanted to do emergency medicine.
Okay. I think we can thank very much Professor Jennifer Cole from Harvard, Massachusetts General Hospital. I am very happy for this meetings and for your coming to Pavia, and because she accepted our invitation to stay with us and to explain better the topic, the information about clinical pharmacy. I think we have to understand and to rethinking what we learned in during these days, during these seminars, and I hope that our connection, our collaboration will improve in the future. Thank you very much, Jenny.
Thank you.
Rimanete un minuto online.
Development of the new National Health Service requires commitment and training. Knowledge and organization must be adapted to the needs and modernized. Scientific and technological development, from advances in molecular or imaging diagnostics to the rapid development of new drugs, instrumentation, and methods, from the perspectives of regenerative medicine to the spread of wearable monitoring tools, designs medicine in continuous evolution, with the patient at the center, who is increasingly involved in his own personalized healthcare process. As a result, the health organization is also evolving toward new models of care, integrating the different specialist skills and services with respect to the clinical conditions of the acute and chronic phases of the disease in an aging population that presents increasingly complex problems. We are therefore faced with new types of therapeutic strategies and with an organizational evolution, both nationally and regionally, that needs to evolve the model of clinical pharmacy currently applied in our NHS. The clinical pharmacy was born from the need to customize the therapy and the approach oriented to the individual patient and his needs. Now is the time to rethink and modernize this approach, providing a more marked involvement in the clinical part to get fully into the new model of care as competent and organized specialists. The clinical pharmacy can develop into a new model of care if it offers professionals and prepared both from a technical and managerial point of view. We will have the excellent opportunity to hear from the protagonists at the forefront of this new service for Italy, which is the collaboration doctors and clinical pharmacists. From USA, Chicago and Harvard, Lexi Osrow and Jenny Cowell will talk about seniors in ED and collaboration in clinical pharmacy.